Good evening, everyone. I'll be presenting our work entitled Navigation Guided Percutaneous Iliac Incision, description of surgical technique with review of our case series. The first description of posterior spinal instrumentation dates back to 1891. Since then, there has been a rapid advancement and refinement in surgical technique, instrumentation, and imaging technology. Spinopelvic instrumentation has a variety of clinical indications. Instrumentation is necessary to have a segmental stabilization and fixation, protect the S1 screw against pull-out, increase the biomechanical stability across the junction, and of course, to prevent the failure of long construct. Numerous techniques have been described from open to mini-open to percutaneous fashion. Image assistance is of absolute necessity because of the complex anatomy, coupled with OARM 2D or 3D navigation helps in safe screw placement. To describe the technique of percutaneous insertion of iliac screw using navigation and intraoperative image guidance. A total of 7 patients were treated with lumbopelvic construct for various diseases of the lumbosacral junction. 5 patients underwent navigation guided iliac screw fixation. C-arm freehand technique was used in 2 patients. All patients had failed medical line of management and had significant back pain or leg pain affecting their daily activities. Description of technique with case example. We had a 77-year-old female who had low back pain since 3 months affecting her daily activities. She was a known case of L4-L5 tuberculous spondylolischitis on treatment. However, neurological examination showed no deficits. Her preoperative X-ray showed compression fracture of L5 with 50 to 70% reduction of vertebral body height. MRI showed altered signal intensity at L4 and L5 with vertebral body destruction at L5 and contrast enhancement. She was planned for percutaneous pedicle and iliac screw fixation under OARM guidance. The patient was positioned prone on Allen frame. Percutaneous pin for navigation was inserted at the superlateral margin of the PSIS. OARM spin was performed and data was transferred to navigation system. Entry point for the iliac screw can be in the midline or lateral to midline, and it is done usually based on navigation, the orange line showing the entry point. Entry point is based on the patient's anatomy and is aimed at anterior inferior iliac spine, not penetrating the joint above the greater sciatic notch. After choosing the optimal trajectory, junction needle is docked at the starting point and advanced forward, simultaneously allowing for real-time multiply images on the navigation screen. Guide wire is inserted in standard fashion and the junction needle is removed. These are the fluoroscopic images showing guide wire. Serial dilatation is performed and screw tap is threaded over the guide wire and is tapped along the trajectory of the screw. Screw is inserted in standard fashion. These are the serial X-ray images showing insertion of screw. Rod is counted from chorda to cephalad in both sagittal and coronal plane based on preoperative assessment and planning. Counted rod is passed from cephalad to chorda in subfacial plane under X-ray guidance. This is the post-operative image. Patient was mobilized on POD1 with significant relief in preoperative pain. This is the wound at 1 week, orange circle showing entry point of the iliac screw in the midline. Imaging done at 4 months and 1 year with no implant failure on X-ray and MRI showing good resolution of disease and patient doing symptomatically better. Moving on to results, our series had a total of 7 patients, among which 2 were male and 5 were female. The mean age was 59 years. There were 4 cases of spondylodiscitis, out of which 3 were tubercular in nature, 2 at L45 and one at L5S1, and the other being MDR spondylodiscitis. There were 2 cases of sacral insufficiency fracture secondary to osteoporosis, and the last one was an implant failure with screw loosening in an operate case of L2 to 5 olive. All patients had no intraoperative or immediate postoperative complications. There was no conversion to open procedure. All patients were mobilized on day 1 with significant relief in preoperative pain. There were no implant-related or wound complications in the follow-up period up to 1 year. However, one patient, 50-year-old, was diagnosed with L5S1 tuberculous spondylodiscitis, died at 3 months due to underlying chronic kidney disease. Discussion. The objective of any lumbosacral construct is to produce triangulation effect, thereby reducing the screw pull-out and increasing the stability. The preferred one is the iliac screw, as it involves placing the screw in zone 3, acting as a distal stable anchor. The traditional open methods has its own disadvantages. To list requires enormous fluoroscopic exposure, extensive dissection of the paraspinal musculature, injuring the muscular and the ligamentous attachments to the sacrum, PSIs, and increasing the post-operative mobility, risk of wound hyacinth, and risk of hardware removal due to screw head prominence or loosening of the screw. The percutaneous method has advantages such as avoids disruption of erector spinae muscle, posterior sacroiliac and interosseous iliac ligaments are spared, lesser tissue trauma, lesser bed loss, contributing lower infection rates and more rapid recovery. Our series had no hardware or wound-related complications. Finally, the use of intraoperative image assistance and navigation renders 3D view of the bony structures, helps in planning the desired entry point and trajectory, and guiding the screw with real-time multiplanar images, eliminating the need of fluoroscope. To conclude, percutaneous iliac screw offers the same biomechanical stability and overcomes the disadvantages of conventional technique. Additionally, navigation allows for 3D visualization, planning, safe screw placement, and minimizing radiation exposure. Therefore, percutaneous navigation at iliac screw is superior. Thank you.